second speaker, okay, Dr. Chua Siew Kuan, who graduated with Doctor of Philosophy in Physiotherapy from the Faculty of Health Sciences, University Kebangsaan Malaysia. She gained a Master Science of Manipulative Physiotherapy from Hong Kong Polytechnic University. She has a certificate of post-basic of physiotherapy in neurological rehabilitations, Ministry of Health, and a Bachelor of Science Honours Applied Rehabilitation Physiotherapy from Teesside University, United Kingdom. Formerly, she works as physiotherapy at 2 public hospitals, and in mid-2007, she joined us at UiTM till now as lecturer at the Center for Physiotherapy. Without further ado, I would like to invite Dr. Chua Siew Kuan to start her sessions. Dr. Chua, the platform is yours.
Good afternoon, everyone.
Good afternoon, Dr. Chua.
Can you see my slide?
Yes, we can.
Yes, we can.
Oh, that okay. I'm using 2 screens. Hopefully, it's working well. Good afternoon to everybody. I saw a few names of my friend, my classmate, okay, from PPUM, KKM, and the training center from Malaysia. So a very good afternoon. So you can bear with me. Hopefully the line is clear. So today we will cover some current trends in acute low back pain assessment. Is the sounds okay, One Ida?
Yes, so far
Okay,
I can hear you loud and clear. And Dr. Chua, could you please change it? Yes, please. Thank you very much.
Okay.
But we can see the speaker notes.
Speaker note now?
We have 2 screens which showing the speaker notes and the slide. I think that one is for speaker. Is it possible for you to switch it back to participants note or audience notes?
Oh,
Oh yes, you just need to cancel that one and then yeah.
Oh, 2. Is it now? Can you see?
But still we can see the. Can we just try to click the display setting, Dr. Chua?
I close first.
Okay.
Yeah, sorry, you have to bear with me. Maybe take a 5-minute rest before you can reach me. Hi.
Dr. Chua, you can click the slide presentation icon or you can just click the display setting icon. On the right.
Show active speaker video. Is it okay?
It come up too small.
Yeah, I also have seen it's very active. How about now? Play down.
Yes, we can see your slide, but it is still not in presentation mode.
Yeah.
Yes, you can, yes.
Now, okay.
But Dr. Chua, can you just click the display setting button on the left top? Yes, display setting button.
Yes.
Swap presenter view and slideshow.
Now is it okay?
Tak jadi juga lah Dr. Chua.
Display mute.
Tadi jadi.
That is slow. Is it okay now?
Still nampak.
Another slide kan?
Ya, betul. Dr. Chua tekan this one is okay. Yes. Yes.
Now okay.
Now okay, yes.
That is slow. Yeah. Okay, sorry for the technical error. Okay. So today we will talk about, I will share with you about the current trends. This is not workshop, just share with you what is the current trends of for this acute low back pain.
Dr. Chua, boleh ke saya bantu lagi sekali sebab dia tak jadi slideshow. Dia just nampak lagi satu slide for presenter. Can we switch? Yes, duplicate slideshow. Duplicate slideshow. The same button just now, display setting, but Dr. Chua click on the display. Yes, that one. And then click. Yes. Now is, yes, Dr. Chua. It is in presentation mode.
Oh, okay.
Okay, Dr. Chua, all the best.
So at the end, hopefully you all can identify the importance of screening in low back pain. This is a focus on acute low back pain, and you can conduct assessment among patients with low back pain. Okay, so the content is about very simple: acute low back pain background, screening and diagnosis, triage and assessment treatment. So acute low back pain. Why is it we need to focus on pain? Why is it important? Okay, so as we know, pain is very unpleasant, sensory and emotional. Why I can see something else suspended. Okay. So an unpleasant sensory and emotional experience. Pain also associated with the actual or potential tissue damage, may be, okay, may not be or may be, always described in terms of such damage. Bear in mind that pain also can be improved with or without therapy, okay? So a little bit about definition, acute low back pain. So low back pain is described here is from 12 ribs, from pelvic to inferior gluteal fold, with or without leg pain. In 2000, UK guideline has stated that about more than 90%, about 90% of low back pain cases will recover within 6 weeks. Okay, how about now? This is 2000. Okay, again, now latest evidence have shown yes, the 70 to 80 most symptoms resolve within 6 weeks. So we are not so proud because we are wonderful, we are powerful to enable patient to relieve pain. Okay, some patient acute low back pain will not reach us immediately in Malaysia practice, but not in Western. Western is they can walk into the physiotherapists. Okay, only 5% have small portion, 5% still suffer persistent and reduced recurrent low back pain, and then lead to prolonged disability. Okay, which may further about recovery. Okay, the trend. Let's look at previous trend of diagnosis. How people diagnose from 2004 to 2011, they found out those who have low back pain always related to comorbidity, high prevalence of chronic hypertension, cardiovascular disease, and diabetic compared to reference population. So adults with low back pain also, they are more likely to have arthritis, headache, osteoporosis, tobacco, or alcohol and any drugs are dependent or abuse disorder. After 2011, you can find 30% of lower back pain have related to depression and post-traumatic stress disorder compared to general population. So based on this trend of diagnosis, you can see if diagnosis is will be changed along the maybe due to IT technology or due to the population thinking, education, high economy status. Okay, so we have to bear in mind what our treatment assessment also will be changed. It have to be changed. Okay. So the recent 2019, they also discuss about this systematic review in Canada, United Sweden, Belgium, Finland, Israel, and Netherlands have come up with a statement that we can see prevalent in Western country is 1.4 to 20%. Why is it so different? Okay, incident is only incident is something like you follow up of people from no pain until pain. That's why the percentage is less. They will calculate whether lifespan, a lifetime of certain duration of year. So the anyway prevalent incident is still have no consistent number. Okay, it's not stable number. Why is it so? Okay. And then they find out high frequency of recurrent low back pain if related will cause leading to personal burden, social and economic burden as well, healthcare system burden. Okay, so this review have highlight that healthcare policymakers have to be critically examine the data source. Where is this population being studied? Okay, this from the Western country. How about Malaysia? We do know yet. We have a study on this Malaysia population. How come I cannot see my slide? Okay.
Dr. Chua, you need to share again your screen.
Oh, now can you see?
Not yet.
Oh, it lost. Huh? Okay.
Yes, it's coming up.
Okay. A lot of signal.
Yes, Dr. Chua, we can see your slide now.
So what attribute of pain? So this reflects that pain can be pain attribute can be due to a lot of factors. Okay, here I would like to highlight person, experience, belief, context factor, intensity of the input. Intensity of input here is people have referred to the area localized damage area. If even the tissue damage have encountered a period of healing after 6 weeks or maybe a long period or shortened period, but the intensity of input, patient may still have have experience of thinking about that is the pain, still experience or register in their mind that the pain is still in situ, and then there is a lot of intensity input activate the pain. This also our pain is also depend pain experience. Some people have multiple pain experience. As for example, like female compared to male. Female may have experienced many type of pain like period type pain, labor pain, okay, compared to men. Men is no. So maybe the pain tolerance, intensity, or perception is totally different. And belief also, belief. Yeah, just like you and me, we are staying in Asia country, we have cultural, multi-races. So our belief also is a little bit different. Okay, for those who have pain, yeah, if they are not searching for, looking for the Western treatment, they will go for, like Chinese will go for traditional Chinese medicine, Malay will go for the traditional Malay massage or some others approach, whichever method convenient to them. Okay? Because if government sector, we have working hour 5 days per week. Okay, and then we have public holiday. Well, pain is never selected. We can only experience pain on certain day. Okay. Yeah, why not? Hang again, not moving. Okay. So the belief is important. Okay? Wherever have a negative belief, if you found that when you assess interview patient, you found that your patient have also kind of negative belief, always think of hurt equal to harm, movement will hurt more, okay, that kind of belief, then it will be you need to stop them from that kind of thinking. So because the study has shown that if you have negative belief, you will predict your pain intensity. So if your belief negative is strong, then your intensity will be stay in your mind longer, and it will contribute to your disability, high disability level, and if whoever working, it will increase the work action, the action or MC, as well as chronicity of your condition. So for those who have positive relief, they found, research found there is less, they have less disabled compared to those who have a negative belief. So belief can be, in statistic study, it showed that belief alone is a independent factor can increase. Okay, it doesn't influence by other factor. Okay, so yeah, surprising that this study they found out the negative belief came from healthcare provider, practitioner. So we are the one part of the healthcare professional. So we have to be aware that what kind of message to be delivered to the patient. Okay, another factor can contribute to recurrent and persistent low back pain. Yeah, belief is the topmost. The second is poor coping strategy. Yeah, there is some people have poor coping strategy and the pain behavior. Your pain behavior means that pain behavior is how the pain what make the body move, because pain will contribute will what I call predisposed to abnormal loading of sensitized spinal structure, feeding a cycle of pain never stop. So even case like absence of a clear traumatic injury that X-ray show nothing, but this behavior such as they can walk, they can behave like still have painful walking with limping, then they have some mindset, then the mindset distribute the message to the muscle, so the muscle over the area will consistently protect, guarding, okay, and more reflective of this kind of behavior, more reflecting of catastrophic thinking. So some example, like people will say, my back is still hurt. I want more treatment. So this kind of patient, you can see this group of patient may more likely to seek for the passive approach, so that you want the best treatment among the best. So you will go to consult this surgeon, that surgeon, this TCM or that TCM, and even the physiotherapy practice from government shift to the private clinician. Okay. So you can see here in Malaysia is very commonly. So how about the image of low back pain spine, low back spine? Role of image here, bear in mind, we have to know that Spine X-ray is only tell you, oh, is there any contraindication reflex, such that is there any fracture? If fracture, I can ask patient to perform a movement, okay, in certain specific movement, or is there any bony fracture, bony deformity? It's just show maybe there is some degenerative changes, sacroiliitis, and this and vertebral body height. Okay, so X-ray is only advised to perform if there is history of physical show no medical cause, mechanical cause of low back pain. Mechanical, that means patient will tell you that, oh, my pain is consistent. Even I bend my this one, I stand my rest, okay, no mechanical. Or if the reflex are present, okay. So reflex, we will talk about reflex later. But X-ray result will never tell you that is this finding will correlate to better outcome or worse outcome, okay. So bear in mind that we can use this kind of information to explain to the patient so that patient may understand, okay, what is X-ray role for X-ray for this kind of low back pain or spine pain, okay. Whereas for MRI, okay, a lot of people believe, oh, MRI shows something, I must do something, okay. So, but there is a lot of studies show that a patient, a population with pain-free, without pain, they also scan using MRI show that 91% have degenerative. This bulge also 56%, and this protrusion 32%, annular tear is 38%. Why? Because low back pain is increasing with age, increasing with wear and tear. So this kind of degenerative, vertebral body degenerative is part of a aging process. But it doesn't mean that you have this aging, you have more painful. Okay, so you have to deliver this information to patient as well. Okay, student also bear in mind that, take a note that always convince patient, reassure patient. This message is not wrong. Okay, so if X-ray occurs for specific acute pain, that is different. Now we are talking of acute pain with non-specific condition. Okay, and then MRI is not predict future low back pain. It doesn't mean, oh, this is very bad screen, or the disc become black color, no more nutrition. But it doesn't show that you can get future higher rate of high risk pain. No, there is not correlation. They also do a big population study show that it does not correlate and does not predict with better what we call higher statistic. So what are the current trend of screening for low back pain if we bear on this? So previously we are advised to screen red flags, yellow flags, or maybe clinician will do blue flag or social occupation black flag. Okay, but here we highlight what is a red flag. Red flag is usually based on the biomedical factor, that means doctor diagnosis. Okay, just like diagnose spine fractures, spondylolisthesis. So the red flag means we have to screen whether they are contraindication for our therapy treatment or not. What are the contraindications? Let us look. This is a New Zealand guideline in 2000. It's quite old guideline. So red flag is talking about we have to screen whether patient have caudal equinal syndrome. Can you remember what is caudal equinal syndrome? So our spinal cord and L4. Okay. So the vertebral spinal cord and at the L1. L1 is the caudal, the tail of the spinal cord. So this tail will never induce a hypertone or what. But these nerve innervations mainly affect S1, S2, bladder and bowel control, medial L4, L5 area like calf pain or foot drop. The main remarkable symptom is patient unable to lift the toes up, unable to do ankle dorsiflex. So they will walk with foot drop or high stepping gait. So severe worsening pain, especially at night or when lying down. Okay, these are the reflex. Okay, like specific time and severe pain. Significant trauma. So when you interview them, they have history of trauma. Okay, then they have a multiple. This syndrome is not single weight loss. It's combined weight loss with history of cancer or fever. Use of the IV drug or steroid, or patient over age of 50. So these are the reflex. Okay. So this is a detail, I think, repeated of what I say. But additional is acute sciatica. So reflex, usually we only screen, but if doctor overlook, we can refer to doctor, right? What are the clinical findings you has been assessed from in respect of subjective interview, objective tools you use. So you say this patient more likely to have reflex syndrome. So please further advise. Okay, then doctor will do investigation. So if patient have advanced activity and the history of trauma, okay, this kind of people, then you say high risk of this reflex. Okay, yellow flag is more like what I call psychos behavior or psychosocial problem. Okay, reflex is like anxiety, depressed, fear. Okay, and others catastrophizing factor. Too fast. Again, my slide is, I think, disappear again. Okay. Yeah, I'm staying in the level 13. This is, can see afternoon. There is a high usage of I see. Sorry for the technical problem. Yeah, getting slow. Okay, so as for the yellow flag, what are the yellow flag we can screen? Okay, so yellow flag is more or less like thinking, negative belief. Okay, they believe pain and activity are harmful, or some they say sickness behavior. They always think my pain is still there. I feel that it's not really recovered. Okay, then they have low mood, negative mood. Okay, bad mood and social isolation. Don't never intends to join partner or peer group. Treatment that does not fit best. So if the treatment for center A is not good enough, people see center B from TL, you can run to Seremban. Yeah, there is a lot of our population, community people, they always from one stage to one stage to get the best treatment. Okay, problem with the claim and compensation, history of back pain, kind of this kind of claim, problem at work, poor job satisfaction, everything is not satisfied. Okay, heavy work and sociable hours. Okay, they always focus on work, but never think of how to take a rest to release tension. Yeah, again, sorry, my slide is not moving. Sorry. Yeah, so lately comment on the reflex screening. So they say clinical utility of individual reflex is increasing question. Why? Because you can see a lot of patients with cancer. At the end, they say this fella is end with what it call stage 4, stage 5 cancer. But when they have no symptom of night pain, they have no symptom of night pain and weight loss. Okay, or fever even. Okay, so most have a limited sensitivity or specificity. So this is 2013 they comment. So the latest 2019 by the expert O'Sullivan group, they say we need to combine sign and symptoms for screening reflex. So we cannot base on solely night pain or weight loss. So we have to base on the severity of pain, fever, unexplained weight loss, neurological deficit combined with subjective screening, confirmed with the objective examination. Okay, night pain and prolonged more than 30 minutes of morning stiffness. Okay. So based on this in mind, so we still carry out the basic what I call acute low back pain assessment. Okay, so we can use variety of assessment tools based on our population. Okay, if the population can't really express their pain in figure, in number 1 to 100, or in number 0 to 10, then you put it 1, 2, 3, 4, 5, moderate, mild, severe, extreme. Okay, some they familiar with this kind of round meter. Okay, so acute pain can be reliably assessed with these three tools. Okay, but bear in mind that when we interview patients, don't only assess the pain at rest. We want to emphasize pain at movement, pain during specific function. So we put it as an asterisk so that we want to code this complaint, okay, assessment pain related as an ongoing assess to monitor progression of the disease, or also monitor effect treatment plan for pain. So other question you can use, this is I'm taking from one of the journal, a simple question like, do you have any ongoing pain? So some people say, okay, do not quote pain because the pain itself will the increased emotion experience or painful, unpleasant experience. But you can say, do you have any ongoing symptom like this? Okay, say symptom or speak sensation like this. Okay? If yes, then you have to take specific. Where is your pain? Is it localized? Sorry, is it localized or so go back. Is it localized or extensive area? If localized, when we also interview, is it superficial or depth? Okay, deep. How deep is deep? If superficial, we know, oh, maybe the muscle or skin involved. Okay, or if it may be a superficial what you call structure involved. Let's look at low back pain. Yeah, low back pain. Which part of the body is considered superficial? Maybe iliac crest, lateral to the iliac crest. Okay, so maybe patient can pinpoint. When I enlarge the signal, the color is gone. Sorry. So low back pain. Let's say quadratus lumborum area. Okay, that is the waist part. So this part can show some, because of huge muscle bulk, it can show a spasm guarding, can be localized. If people say the pain is referred to the buttock, and then we can say maybe facet joint. Okay, the kind of interpretation. Okay, facet joint, like when patients say I have go back more painful, when I bend a little bit forward, I feel comfort. Okay, so facet when you impinge it, when I turn my back, pain. Okay, hello, yes, anything? So ask patients to rate their pain on the onset or now. Always, if you use body chart, always record the pain now, okay, not the previous. If you ask previous, ask progress of the previous condition. Let's say if
Okay, participant, please bear with us for a while.
thinking,
I think Dr. Chua.
don't.
Dr. Chua. Dr. Chua, you are breaking out. I still can't hear you, but the connection, I think, is getting poor. But we can still see your slide, Dr. Chua.
can see slide, but can you
Yes.
hear me?
Yes,
Then
now I
on and
can
off.
see your face and yes.
Yeah, on and off. Sorry for the this. Yeah.
No worries.
So we need to be fast. Okay. So we go back to the pain. Ask patient to rate their pain. Okay. So make sure the pain assessment is now today. Okay. So because whatever documentation is today. Okay. If patient have this explain a long story from pain until today, yes, you can put it under pain. The initial onset. Okay. How is the pain like? Or how pain is the severe, how bad is the pain. And then we also ask, do you think your pain is getting worse, getting better, or still same? Okay, if getting worse, do you what are the things getting what are the activity or motion worse? If better, I think you're done. So if they have in the we know, remember 6 weeks. No pain also can be resolved. Fiber, the hair muscle fiber, or maybe for low back usually it's muscle. Okay, because knee we can say that is ligament. Okay, low back is mainly strain. Okay, so muscle. So we have to investigate more on pain. Okay, so that we know the clinical features of pain, then we can address it better. What, if any, do you take any medication to relieve? Okay, easing factor. Yeah, what are the things make it better? Then you have to ask easing factor, aggravating factor. What, if any, other treatment do you receive for your pain? So this is the way you practice and try to interview patient with this kind of tone of statement. If your pain satisfactory control now, it means that if your pain is well improved and then constant, never progress worse, increase, okay, that's kind of interview. Yeah, luckily it's good. Okay, so also we ask about 24 hours behavior. Why we need to record this? Because we want to know pain pattern. Is it due to the degenerative pain pattern, just like early morning, we know morning stiffness, after some motion that is less, okay? Maybe overuse, evening getting worse. So that is kind of wear and tear osteoarthritis pattern, okay? We need to get some idea of clinical pattern of this kind of pain so that we can assess accordingly, okay? If I suspect, oh, this pattern is acute, is due to the facet joint. Okay, then I will ask patient a lot of questions about when you move your back backward in car, from car. Okay, get up from car, you go backward. Do you have any pain? When you go forward and turn the body, is there any pain provoked? Okay, this kind of question. Okay, so provoking aggravating and easing. Try to ask questions related to daily function. Daily function means that is housewife, they used to stand and do housework or sit and do. So you ask them to recall that kind of activity so that they are more concerned and they can compare the progress. Okay. Also, we ask about irritability. How to ask about irritability? Okay, we ask whether when you have this kind of, oh, sorry, run to next slide. We ask still in subjective, so we ask when you have pain in that moment, how long the pain gone, release. Okay, so if they, oh, if I know if I expect I look upward pain, I will quickly stop that moment. So that is low irritability. Why so? Because irritability will guide you your planning of the intervention. Yeah, is there anything wrong with my presentation? Okay, so irritability will, yeah, irritability will guide you in selection of the technique. Means that if a low irritability, okay, I can use aggressive force. If high irritability, I know this kind of people, I will go to others approach, education approach, Okay, more on convince patient, explanation, and then teach a little bit of sound management, pain management. So after you interview, you are satisfied with your interview information, you roughly have some idea, yes, this patient is seems like to be just degenerative, acute pain due to degenerative, maybe a strain, acute strain, okay? Or you can say, oh, acute pain, acute on chronic, okay, that kind of predict. Then you can proceed with what kind of physical examination I need to do. Okay, do I need to practice perform the neurological test to confirm my my subjective finding? So subjective is very important. Yeah, the usual practice, I will usually we use the guideline from neuromuscular examination from medicopathy. Okay, we first step for in what I call physical examination. Yeah, you will ask patient to perform active physiological motion, but instruction is very careful. This patient with high irritability, then we say, now I want you to check whether you can move forward. Okay, use the word forward, but you try to move it slowly. If your pain is 8, let's say you have pain, so we want this movement maybe 5 to 6 if possible. Okay, so patient would think, okay, I need to move, but not move beyond that. Okay, so the instruction keyword must be clear to patient. Okay, then if no pain reprovoked, then we ask, can I do some pressure or what and range task, see whether you can move a little bit more. If patient have still no reproduced pain, then we proceed with the overpressure. Okay, overpressure is something like you press and a little bit more pressure to feel end range feeling in between, end range between bone and bone, ligament kind of feeling. See whether it's still hard or soft. Okay, they give you some idea. So the active physiological movement has shown in this picture. Okay, for 6 degrees of freedom. Okay, forward, backward, side, rotation. So all the instructions must be, maybe you can have this diagram shown in the wall. So I want you to perform this motion. After that, next. After that, next. But be careful. I will just want you to move past your pain 5 to 6, not beyond that. And then tell me that is the pain. Okay. So after that, we ask patient, is the pain is similar to you come into physio, to the moment you walk in, or the usual complaint? Because a lot of patients, they have pain, acute pain, but you ask to do others motion, they another new pain, new complaint. But we don't want, we want to focus on patient complaint when walk in, or the patient doctor refer the pain to physio. We want to highlight that problem. Okay, the latest, that is our practice, but latest literature mentioned, we need to add, if you found your patient, if you found, oh, this patient is some symptoms, seems like to have some relief or some emotional, then they suggest you can further assess with self-reporting questionnaire using bad depression inventory, okay, or you using profile of mood stage or global depression impression of change scale. Okay, so you can search this, use this keyword and search how to use it and practice. I have never practiced this before. Then the finding is clinical, for clinical meaningful change. Means that you need to have 5-point decrease when you use this question now. What is a 5-point decrease? Means that when the scoring 5 point is really indicate you have some benefit change. Okay, if less than 5 point is still not enough, not satisfied yet in clinical important. Okay, we want to see based on this questionnaire, 5-point change can reflect you can be able to perform a lot of functional tasks, okay, with bearable pain. Okay, so the profile and mood state also, it must be have 10 to 15-point change, because they have done a study to show that must have 10 to 15 indicate a meaningful change, okay, meaningful to patient able to achieve some task, maybe can maybe to achieve high level function. Okay. Okay, next. This is just now is something new, is emotional assessment. Okay, how about the intervention? Okay, the previous intervention guideline I managed to download 2007. Okay, 2007 have said that 2007 because say that bed rest more than 2 or 3 days is not benefit, is harmful. Okay, you make the patient passive demand, fear to move, that kind of thinking. Ineffective and very harmful. Then so
yeah,
yeah, is it? Yeah, sorry. Yeah. Okay, so so we have to make based on this, they come up with instruct patient to remain active. Okay, to the moment I touch my mouse, it's too sensitive to touch. It become yes. Okay, so level E evidence is good evidence. High score of ranking quality of paper. So the specific exercise is not helpful from 2007, means that when patient in pain, yeah, whatever exercise, especially you do isometric trunk extension, or isometric multi-feeder exercise, that's not helpful at all. Okay, the only helpful is maybe doctor can prescribe what I call non-steroid anti-inflammatory drug or muscle relaxation. Okay, these are effective for first-line medication. Is beyond our role. Okay, level B is say that yeah, hot pack heat therapy is more easy, it's better. Yeah, so I also practice hot pack in clinical year 2007 to 2000, yeah, something 2010. So maybe helpful in reduce pain and increase function. Why they always put maybe? Yeah, because some patient yes, some patient no, but you can suggest they proceed. Okay, spinal manipulation therapy. Yeah, Western people, they have undergraduate also, they have some spinal manipulation therapy training. Okay, may offer some short-term benefit. So be aware that short term, maybe 6 weeks, we can do it, but after that, no. Okay, you have to stop it. But no more effective than usual medical care. After that, it's no more effective. Level C is saying, oh, you need to add education. Okay, education on what kind of activity you need to do. Okay, what are the aggravating use? Please don't do this, that kind of aggravating factor. Explain also natural history, expectation, time cost for improvement, may speed recovery for low back pain and prevent chronic low back pain. Okay, so the main what I call goal for acute pain is prevent chronic. Okay, prevent chronic. But the best practice 2020, what are the something new? So say provide reassure and advice to stay active. So to stay active still consistently being practiced since 2007 until this review. Okay, we need to establish a good rapport between patient and therapist. So a good patient therapist communication is essential to achieve a collaborative rehab. So remember, always empower patient to take over the rehabilitation task. We are the teacher. We play a role in educate or train, identify the muscular problem and train them. Okay, so we want them to comply to our planning. Okay, of course, the planning as a treatment should be negotiate goal with patients. So the physiotherapists, general practitioner have to consult these collaborative to engage patient in their treatment. So, yeah, patient-centered approach of the highlight. Okay, the latest practice is always advised. Do depend on bio, psychosocial. Okay, we understand what happening to that. Identify the factor. We put the factor identified into a good education package, and we address if they have the psychological problem. We address this. Okay, if you are not, if your center have no expert, send to a paying team who are the expert team. I think in Malaysia they have established pain approach team, but this is more chronic. But do bear in mind that psychology aspect is mainly in charge by clinical psychologists. Okay, biopsycho perspective screening page, we can help in screening, provided you are familiar with screening too. Okay, so we have to screen to get this, get to know this kind of patient is high risk of ongoing chronic pain or disabling low back pain. So patient-centered approach. If patient, you can say you can give some choice priority. If patient is not prefer the exercise you suggest, you can give more others option suit patient's environment or status at that moment. So patient-centered approach to low back pain care that address the biopsycho influence of on the disorder, the disease or the condition itself. Of course, the exercise should be tailoring management. Okay, whatever you use for patient A, please do not use for B. Okay, so maybe you use more education on understanding of condition, anatomy aspect. But patient B is from physiotherapists who have a low back pain, or maybe rehab doctor with have a low back pain. So their background is strong in anatomy, so you need to address whatever problem. Okay, so empower patient to activity self-manage. Yes, we need to empower, especially now in this during this pandemic called COVID-19. Patients do not allow to enter as appointment state twice a week, once a week, maybe once a month or so. We cannot, the patient cannot enter hospital, especially in the red zone hospital, Malaysia, in Selangor, in KL. Okay, that's time for you to start your tele rehab. Introduce what are the things should be emphasized. Okay, yeah. How long should be patient discharged from acute? Progress means progress should be reviewed in 7 to 14 days. Means that when you have complete your subjective assessment, confirm with objective, you have come up with solution. Okay. Analysis. Yeah, the impairment of this pain is most probably due to you have checked muscle in muscle length or muscle fiber, so you allow healing. Okay, but your short-term goals should be short, not too long. The long-term goal should be maybe 6 weeks. Long is 6 weeks. Short-term, maybe you have to review every week. Okay, so you set your short-term goal to achieve pain reduction using VAS by 3 units per week. Okay, 1 unit. So 1 week later, you check, is it reduced 3 units if patient at severe pain? Okay, is it reduced by 7 days, sorry, or reduced by 14 days? You decide. Okay, so you need to address the progress. Of course, the promise for patient is every single visit you have to show some improvement in pain. Okay, in pain related to movement, pain related to function. Okay, then only you call yourself an efficient, effective physiotherapist. Kan? Okay, no recommendation as to the level of pain allowed. Okay, so far no recommendation to say how much exercise you should do, but they advise not helpful. Not helpful means that if necessary you do, but don't simply introduce because the theory say, or because my sifu say, my teacher say, because people do it. Okay, do not have this kind of assessment. We need to be what I call practice as evidence-based practitioner. Okay, no recommendation. So far that no specific say, oh, if pain 5 you do this, pain 3 do this, because pain is still a subjective based on patient experience. A lot of factors influence the pain perception or pain intensity. Okay, so even though pain has been quantified into 0 to 10, but if you assess a patient from Asian, from Western, a patient, what I call female compared to male, okay, 20 years old compared to who have experienced multiple pain compared to older people, okay, older adult, not older people. So the guidelines should be used to given return to normal activity. So we ourselves as a healthcare practitioner or physiotherapy, you have to provide a good guideline. Okay, what are the do? Encourage more and do. Okay, previously I don't, but the don't is we encourage. Can you do a little bit beyond that? Okay, so we have to convince patient movement beyond that is no harmful. Okay, you explain why. The healing process is take over by how many days? If there is a fiber tear, yeah, there should be a recovery date. Okay, as long as you constantly using a pain management to minimize to reduce the inflammatory phase. Okay, so referral made for an individual. Okay, so if you think your patient after 7 to 40 days have achieved some expected outcome, then you want to start exercise therapy, go ahead. Okay, so but you need to decide single exercise alone is better or a group exercise is better. It depends on patients prefer, and you assess whether this patient needs some peer group. Peer group means similar back patient to what they call motivate each other. Is emphasize on peer neuroscience education. So of course that is for chronic, but we can use the same model for acute patient and until something new coming up, some new research. Okay, so you can do a research on your population study, because every what you call population in Asia and in Malaysia, in Selangor, in Kuala Lumpur, the lifestyle is different. Okay, in city and rural area is totally different. Okay, education and care here. Why we identify risk factor from theory? We know this is this high BMI in Malaysia study 2018 by University Putra combined with others. They found out people what you call office workers who have BMI more than 25. They have high risk to have what I call low back pain. Okay, so we identify this factor and then put it specific attention and then educate patient. Okay, your theoretical, we have known these are the factors may influence pain. Okay, so in order for you to have good sound management, good recovery, we need to address this. Okay, when I study in Hong Kong, every patient they refer to psychiatric, psychology psychiatric center. I was wonder, is this patient look like psychiatric problem? No, they say in Hong Kong, the what they call lifestyle is very stressful. Yeah, everything is fast and money. No money, no talk, because you know a single square feet of room to rent is about 4 to 5,000 is a single bed. Okay, not a room. Just like Malaysia, 4 to 5,000 you can afford to rent a good facility of condo. Okay, that's why every patient refer to psychiatric center, refer to the clinical psychologist. In Malaysia, in any countries, that kind of you experienced this psychology because of the pandemic, COVID-19. We are social isolation, distancing, but we have been isolated for so long. Okay. So all syllabus, I forgot to put this. They come up with statement that a burden of low back pain is due to the dominant biomedical approach. Means that as a physiotherapy, next time don't even based on doctor diagnosis. Doctor diagnosis is they plan whether to do MRI, whether to do X-ray, or whether to do operation or injection. Whereas our treatment is whether the patient's pain will affect what we call movement dysfunction. Movement analysis have to come in. Okay, so we have to address movement limited due to what? Due to joint problem, or due to muscle tightness, or due to the trigger pain, the muscle tear. Okay, so we are the one a little bit different. We have to rely on our physical diagnosis. We cannot depend on 100% depend on the doctor diagnosis, because doctor diagnosis or investigation just to tell you that, oh, this patient is really safe to do this, but we have to do that with precaution. That is information to you. Okay? You yourself have to be independently good in assessment. Okay, so how to be a good? We have to align with evidence. Always read search article, because now there is a lot of free access web article. Okay, so compared to those days, we cannot access at all. We have to buy the article and the hardbound, hard copy. Now it's soft copy online. So you have to always align with, as a healthcare practitioner, align with current evidence-based practice. And the practice should be biopsychosocial. Okay, address biological, psychological, social perspective. Okay, and another part is we have to increase adherence, compliant operation to the physiotherapy planning. Okay, adherence is very important. You can say that is good, patient in front of you, yes. But at home, do you think the yes is 100% yes? No. Everybody, we are not sure. They are not practiced as what we did unless they are really in pain. Okay. And then patient-centered target. So we have to really plan a goal or treatment, negotiate with patients so that they will do it daily, rather than we design a beautiful exercise, must do with this, with that, but at home they have nothing. Okay, so this is the current this also, no, just ignore this. So this means that in patient is, if the patient in acute stage, do not try to convince patient to learn this and learn that. Okay, as long as you can solve the problem immediately, they will really listen to you. So why? Okay, that is how many years? I can't remember. I forgot to download. That is the latest 2002 or 2019. The effect of exercise in patients with acute low back pain. You can see systematic review of systematic review means that there is plenty of guideline, review talking about low back pain. So what are the findings? What is the finding? Yes, low and high evidence type of exercise. So the finding tell you that as long as patient move, no matter they move with general exercise, yoga, or they move with stabilization exercise or McKenzie exercise, there is similar result, improve pain and disability. Okay, well, of course, you as the assessor, we need to know what kind of exercise patient prefer. Okay, so there's more option for patient, and very low to moderate. So there is exercise therapy. Is no important difference in pain. Okay, yes, they compare this evidence. They compare general stabilization, McKenzie. There's no significant difference. Means that you can ask patient choose any exercise as long as they move the part. Okay, the selected part. No important difference in pain. They in statistics, in research, they are always measure, is there any important meaningful change, clinical important change, means that it's changed by pain 3 units. Is it what they call reflex change in a disability score by how much? Maybe by 2 or 3 score. So exercise compare with, they also study article also address exercise therapy compare with if we use ultrasound with no output or usual care, whatever they do. Okay, spinal manipulation, advice to stay active, education booklet. There is no important difference. Same, because the same effect means that in acute stage you can now this condition situation, we can pump in a lot of education material, education booklet. Okay, just advise patient stay active, means that don't sit for long, don't stand for long, move around. Okay. Yeah. I think okay. In latest review, they come up with some diagnostic triad. Okay, quite triad, not easy to pronounce. Okay, so what is this information about? So it tells you that in actual fact, we know there is minimum case can categorize into what I call reflex. Okay, 5 to 10% is due to what I call reflex called the equinal, blah blah blah, and then that 1 to 2% is mainly due to cancer, fracture. Okay, this kind of thing. So we need to focus on 90% on non-specific low back pain people. Okay, we need to target this group of people so that they are not what I call they are not leading to chronic low back pain and some psycho behavior problem. Okay, that's ending. Maybe okay, never mind. So, so just a little bit about this. So they for this model, they divide based on whether low risk to what they call end up with psycho problem, medium risk or high risk. Okay, so the treatment proposed is they always focus on biopsycho aspect as an education, okay, and then pain management, advice to remain active. Okay, so this is current trying to guide you. So they also suggest what are the words you need to deliver to patient, what are the words you should not talk to the patient. Okay, so don't talk to the patient that your back is damaged, you have the back of very old kind. This is surgeons they used to talk this so that impress patient say, oh, I need help, can you do operation for me? Can okay, so this is a wear and tear. Okay, so these are the words you can search it from the address concern about image. We also have to talk. We have to also tell that image result. Okay, the positive part. Okay, so always tell that pain-free people have no pain, but they have severe MRI or X-ray result. Okay, this kind of message. So I think that's all about what is current trend of assessment. Okay, the good assessment will lead to good treatment. Okay, choice of treatment. So I end my talk. And is there any question?
Thank you, Dr. Chua, for sharing a very informative presentations. Yes, we do have a question in the chat box. Let's start with the first questions. The first one, I think, yes, from Cik Yunus. Is there any grading of irritability? How you grade or define high, medium, or low irritability?
Okay, yes, good question. Okay, yeah, this question I've been I think so far I still haven't read any what it called a paper, but we have been, I have been trained in master level. Yeah, there is some documentation using VAS, VAS score to address this one, irritability. Okay, so you can use just like VAS score, you can use high, low, medium. Okay, but you need to define what you mean by high, what you mean by low, what you mean by medium. If there is no standard, then you just use what I call number to address this irritability. Number used exactly like 0 to 10, like VAS. Okay, so we can say VAS irritability. Okay, at least there is no specific irritability, also no specific documentation or statement. So this is only way we can start it off. Okay, for comparison purpose or for monitoring progress, or patient also can know, oh, my irritability seems to be less. So that is also, I forgot to add on the evidence from literature. When you assess the progress as subjective assessment, objective assessment, the progress report, you need to record subjectively, objectively. So you need to train a student or train yourself which are the most significant, remarkable concern of patient in terms of subjective. And for objective is that you choose the most severe symptom and most limited outcome. Okay, let's say pain, extension very limited and pain, I choose that. Okay, but you need to add on satisfactory level. Okay, in overseas, they are very emphasized on satisfactory level. Even in Hong Kong, they always, the last question was asked, how much satisfactory you regard, but what about our treatment or your progress? Okay, the satisfactory level. Yeah, that is what I call literature mean, also highlight that you need to add on this satisfactory level. Pertain to regarding to your treatment or your treatment approach or your service. Mr. Yunus, am I answer your question?
Mr. Yunus?
Thank you, thank you.
Yeah,
Okay, Dr.
thank you.
Chua, we
One
move
lama,
on
kan?
to the second questions. We have here from Nor Ain. Doctor, may I have your opinion? What is the current practice in low back pain assessment for patient with osteoporosis, has undergone bone mass density assessment, and the result was poor? How gentle shall we apply provocation symptoms, as I don't want to cause any harm for these types of patients?
Yeah. Yes. Yeah. For what I call DEXA result. DEXA result also you need to read whether the result is, because DEXA is they scan the femur, they scan the hip, they scan the triangle area, the femur trochanter area. They also scan the vertebra. Okay, so you need to check vertebra level. Okay, because vertebra density, vertebra body density, and the femur density is totally different. Okay, so our vertebra is like sponge like its tendency to get fracture. So if you have what I call X-ray to show is there any history of fracture? Okay, if patient have history of femur fracture, there is a screening tool, is WHO flex screening tool, told that, inform that if your family member, let's say your mother, have history of fracture, then you yourself have high risk of fracture. Okay, because this, and if you have college fracture before at age of osteopenia or at age of 35 or 40, this fracture means that you fall from level height, bukan jatuh dari tinggi, not fall from height. Yeah, it's just like you walk a level, same level height. You fall down, you fell down, you have fracture. Okay, so that is also a lot of articles show that too much of extension is harmful. Okay, because when you extend, the what I call vertebra spinal process, and the other part is what I can't remember the name of the part that it will cause that there can tendency to have crack fracture. It's near to the laminate area, okay, the spine. My PhD study is on this osteoporosis scan. I also do a lot of back extension, but bear in mind that back extension also you can do unless you have an assessment tool. What are the assessment tool? If you have handheld dynamometer, you can assess in sitting rather than prone. Yeah, here is that people be careful on extension, extension in in prone. But there is a exercise show that by Sinaki 2002, I think, or 2012, this group of osteoporosis people study, they design a backpack of the a backpack put on the patient back. Then they design this exercise, prone lying trunk extension. It seems that this trunk extension, I can't remember for how long. I think it was quite a number of months. So it showed that the effect of delay bone loss will sustain for 2 years. Okay, but they still perform trunk extension. So the best is when using the clinical assessment, like patient have pain or patient have change of the, because if patient come with thoracic kyphosis or we come with flat back, so from that baseline you are only allowed a little bit of extension. If you choose prone lying as an assessment or as a treatment, you can see they are not able to bring the head up, so they are bringing their head up with neck up. Okay, we don't want compensation movement. So the safe is we use sitting, use hand dynamometer. That means it's something like JAMA, but if no hand grip. Therapists have to grip it and the patient stand and ask patient to stand again. That will be, if you want to strengthen that, because improve because their daily life is not anymore. Can be my answering your question?
Dr. Chua, you are breaking. Dr. Chua? Yes, you're still around. Dr. Chua? All right, I think Dr. Chua is asking whether has she answered your question. Yes, Dr. Chua, you're still around.
Yeah. Then okay. Then I can read the. Is there any more question? If no more, I think.
Can I just go with the last question? I think I'll pick up from Nur Atika. With regards to biopsychosocial approach in managing acute low back pain, what is your view on cognitive functional therapy in management of low back pain condition generally? It's about biopsychosocial approach, Dr. Chua.
Yes, just now, like last slide, Dr. Ida, can you still see my slide? Yeah, boleh tak nampak?
Yes.
Remember this a patient, and here I make it. Boleh nampak? So this model has show that they address cognitive problem. Okay, but cognitive usually they refer to clinical psychology, because psychologists They've got a lot of multiple questionnaire to test patient. Okay, they also have multiple technique to make the patient relax and tell the true story. Kan? In this model, the pain management thing doesn't mean you are the one of the therapists. Okay, there is also OT, PT, anesthetists, doctor, nurses, and what I call clinical psychologists or psychiatric also. Psychiatric can prescribe some this. So they also address cognitive. Of course, you need to know cognitive. What you mean by cognitive? There's certain cognitive is if they have some, you can use a normal mini cog test. What I call dementia, minor dementia. Yeah, you have to be be selective treatment to address their dementia patient. Like I have experience, my mother is dementia patient. Her pain perception is different. Okay, sometimes it's very painful, sometimes it's not. So we cannot rely on this, but we cannot treat them exactly like what we plan. Okay, we just to comfort them, make them happy and satisfied. So certain patients, yes, we cannot really use whatever model, whatever ideal assessment or treatment. But bear in mind that we try to solve their problem by using a lot of approach. Okay, convince patient, make them comfortable. Okay, you address what is lacking in this patient. Some patients do need some support from because they are lonely. Okay, they are lonely. They know therapist is professional, can be approached, can be entertained. Then they pay for it. You have to entertain them. Am I right? If you even in government sector or in private sector, as long as they are client, you need to address client problem and entertain them. So you can use this model. This model is addressed by your psychosocial aspect. Okay, yeah, the team is if you have this team, if you do have this team, you can consult, I think, HKL team pain management. Yeah, they do have this team. They of course they address chronic as well as acute, but they do have expert in psychobehavior or cognitive behavior therapy, cognitive therapy. Okay. Just because I think they never advertise their service. Just like government never advertise they have memory clinic. Okay, until I experienced this, I know, oh, everywhere got memory clinic. So they screen for dementia. Okay. So am I answering your question? Hopefully.
Yes, Dr. Chua. Thank you very much for your
So remember that now our approach is more on
plus.
psychobehavior, not solely on pain. Okay.
Yeah. So thank you so much, Dr. Chua. Once